So moving on to the second type of joint disease, here we officially have inflammatory joint disease, commonly called arthritis. This would be typically referred to also as rheumatoid arthritis. So inflammation is a major part of it. It is characterized by inflammatory damage or destruction within the synovial membrane or the arterial cartilage, and then there are systemic signs of inflammation. So this is body-wide. You can develop fever, leukocytosis, malaise, anorexia, hyperfibronegemia, and the beginning of this process can be either infectious or non-infectious. Either way, this inflammatory process begins. So, with rheumatoid arthritis, or sometimes just referred to as RA, and osteoarthritis is sometimes referred to just as OA, this is inflammation that, even though you may feel it systemically, it is going to be based in the joint. You have systemic autoimmune damage to connective tissues, and primarily you see that in the joints with the synovial membrane being destroyed. There are similar symptoms to osteoarthritis, but one way that this test can be, or this disease can be tested for, would be the presence of these rheumatoid factors, and this is going to be called the RA or the RF test. And the rheumatoid factors are simply antibodies, IgG or IgM isotypes, against yourself. So here's a typo. It's not against antibodies, but it's antibodies against yourself, against the joint tissue. So these antibodies go to the joints. It causes inflammation. And then because of that inflammatory response, you have an inflammatory exudate that can develop. So the pathogenesis, you can look at figure 3920, and that slide is actually in just a few slides. So we'll get back to this. You can look at it but also pull the figure 3920 with this. And I'm going to skip this for now and talk about it when we get to figure 3920. All right, so how do you evaluate rheumatoid arthritis and basically differentiate it from OA? All right, you have to have 4 or more of these present. So you have morning joint stiffness lasting at least an hour. A lot of times we can get up in the morning and we can feel stiff and maybe some pain in our joints, knees, ankles, whatever, but that goes away within a couple of minutes of just moving. All right, with RA, the pain, the stiffness is going to last for at least an hour. You have arthritis in 3 or more joint areas. Typically, you're going to see the arthritis in the hand joints. Right? It's going to be symmetric, meaning if you have it in one hand, you're going to have it in another hand, or the other hand. You have rheumatoid nodules, and the rheumatoid nodules are a little different than what you see with OA, in that these rheumatoid nodules can actually appear anywhere on the body. They don't necessarily have to be in the joints, but they can be on the back even. All right, they're going to be places where you wouldn't typically think about joint disease. All right, abnormal amounts of that serum rheumatoid factor, all right, those autoantibodies, and then radiographic changes that you would see in the joints. So those rheumatoid nodules, all right, here, in this figure they're called subcutaneous nodules because they're simply underneath the skin. So in this case you see them kind of behind the knuckle joints. They're not actually in the joint itself. And as I mentioned, you can see them in a variety of places, including the back. With the rheumatoid arthritis, you can get this ulnar drift, and this is where you're going to see some of those radiographic changes. All right, I like this picture. A couple of them, I mean, for a variety of reasons. One, it's cartoon. Gotta love cartoons, makes things a little easier to learn and to grasp. But here you have the synovial fluid. All right, that should be nice and clear. And then here's your cartilage. What happens with rheumatoid arthritis is this pannus develops, and this is grimy. It is exudate, basically, and it's just nasty stuff that is going to inhibit the proper movement of that joint. You have lymphocytes that are going to move into the area, macrophages, these fibroid-like cells, plasma cells, to produce the rheumatoid factor. All right, and this gives you a better idea of what's happening. All right, you have those antibodies that are coming into the synovial, or into the joint, into that synovial fluid. That's going to initiate inflammation. Macrophages are coming in, and through that process, the pannus develops. And with that continued inflammation, you have breakdown of the cartilage. You have breakdown of the synovial membrane that you see nicely here in the normal joint. And then all of these other immune cells. All right, you have the dendritic cells, the immune complexes. You've got lymphocytes that are coming in to produce and secrete the antibodies. Potentially even T cells are coming in and causing damage. So here's figure 3920. All right, up here you have whatever causative agent that is initiating the process of this arthritis. All right, you have antigen up here. It could be some environmental agent. It could be an infectious agent. Whatever the cause is. And then also there is a genetic susceptibility, which you heard about in the Khan Academy video. If you haven't watched that, do watch that. But you have both of these activities that are going to activate CD4 helper T cells. Probably B cells. And if you remember, the CD4 helper T cells are going to help everything along. They help everything along by producing cytokines. All right, those cytokines secreted by the T cells stimulate the macrophages and the fibroblasts. More cytokines are produced, more fibroblasts, chondrocytes come in. You have synovial cells that are being activated. You have further enzyme release. All right, collagenase breaks down the collagen. PGE2, different prostaglandins. All of these components are going to lead to the pannus formation, help with the joint destruction, that cartilage fibrosis, the ankylosis, the T cells, the macrophages, fibroblasts. You have what's called rankle that is released. The rankle is going to activate osteoclasts. All right, again, furthering this joint destruction. And then activation of the B cells because of the T helper cells. You have formation of those autoantibodies. Then you have autoimmune complexes that come in and be deposited into the joint area that further exasperates the inflammatory response, that further exasperates the joint injury, and you have furthering of the pannus formation, the joint destruction, cartilage fibrosis. All right, now gout is a metabolic disorder. You've got another video on this. That video is actually really good at describing what gout is. And it's a metabolic disorder that disrupts the body's control of uric acid production or its ability to excrete it. So yes, this is metabolic, but it's going to manifest itself in the joints and in the muscles. So gout manifests high levels of uric acid in the blood and other body fluids. Then what happens is that uric acid is going to become concentrated, and it increases to high enough levels that it crystallizes. If you remember the step-wide process of kidney stone formation, what do you have? You have a supersaturation of a variety of different chemicals, maybe calcium, and then that high concentration supersaturation leads to precipitation, it crystallizing, it falling out of solution into a solid form. And then with the kidney stone formation, then you have the growth. All right, and you're going to have that same process occurring here with gout. The crystals are going to be deposited in connective tissue throughout the body. And then these crystals occur, or when these crystals occur in the synovial fluid, then we just finished talking about osteoarthritis and rheumatoid arthritis. Those uric acid crystals cause inflammation, and then a person has gouty arthritis. So how is this characterized, or how do you know that you have it? Generally, you have sudden severe attacks of pain. You have redness and tenderness in the joints, and a lot of times, for whatever reason, the big toe, the joint at the big toe is like the go-to joint for gout. So this is a complex form of arthritis. It can affect anyone, but men are more likely to get gout. But women tend to have a higher propensity to develop it after menopause. And an attack of gout can come on very suddenly. You can wake up in the middle of the night with the sensation that your toe is on fire when you went to bed and everything was fine. So the affected joint is hot. It can become swollen and tender, so that even the weight of a sheet on it is intolerable. So you have intense joint pain, you have lingering discomfort, inflammation, redness. That inflammation and pain can lead to a decrease in joint mobility. All right, so gout is related to purine metabolism. All right, purines are the adenine and the guanine. And you have dietary purines, so anything that you eat has DNA in it of some sort. And that DNA is going to be, a fair amount of adenine and guanine, about 50%. Your body is also going to synthesize its own purines because you need your own DNA. So you have this process of synthesis and you have metabolism. All right, the body's, you have metabolism of body purine nucleotides. All right, you have tissue nucleic acids, and the body purine nucleotides will produce purines. You have dietary purines. The purines get broken down into uric acid, and so there should be intestinal excretion and renal excretion. All right, but if this process goes awry, then that uric acid stays inside of your body. So you can have accelerated purine synthesis, breakdown, or uric acid secretion. Mechanism for crystal depositing or deposition. All right, lower body temperatures or decreased albumin. So lower body temperatures, that's why often you see it in your big toe, your feet sometimes, decreased body temperature. It can be an issue of trauma. So a person who might be on the verge of developing gout can stub their toe bad, and then that trauma in the joint can actually lead to developing gout. All right, and below this slide in your notes, you've got quite a few areas or it talks more about gout in terms of diet, limiting your amount of this dietary purine, limiting alcohol consumption. All right, obesity plays a role, so if you're overweight, your body naturally produces more uric acid, so you can lose weight. Yeah, so this is gout. Good topic.